The next talk, thanks a lot. The next talk is going to be given by Nuria Oliver. I had the kind of contact with Nuria as we started ourselves to look into this problem many months ago. And we had a very nice conversation about her activities in Spain. And she's from European Laboratory for Learning and Intelligence Systems. And I also told her maybe European community or European politicians use the word intelligence there and think about independency. Nuria, the stage is yours.
Oh, thank you. Thank you so much, Ahmad. It's a pleasure to be here. And I really appreciate the time pressure to because I have a constraint. So thank you for that. So as Ahmad said, the reason why I'm here is because since March of 2020, I had done a lot of work on the use of data and data science for what we call social good or for the public interest. And I reached out to both the Spanish government and the Valencian government with the idea of creating a team of data scientists and researchers who will be working closely with the decision makers in trying to close the gap between where the data is and where the decisions are. And my idea was very well received by the president of the Valencian region. And basically they named me commissioner to the president on AI and data science for COVID-19. And we've been working on 4 large areas that I don't have the time to describe right now, but I will mention in my presentation the results, some of the results of the last area, which is a very large citizen survey called COVID-19 Impact Survey with over 400,000 answers so far on the situation and the perception of people during the pandemic, but also on their contact tracing app usage and on how much manual contact tracing is happening and so forth. So as you know, we've been 8 months into this pandemic and 2 waves. And what we definitely know, and we knew that before the pandemic, is that if we want to minimize the spread of a human-to-human transmitted infectious disease, it is fundamental that we detect as early as possible the maximum number of positive cases, so those cases isolate themselves, and therefore we can prevent community transmission. And this leads to the well-known TTI strategy: trace to know whom to test, to know whom to isolate, and therefore avoid isolating the entire population, which is the last resort that you use when you don't know who the positive cases are, and then you end up isolating everyone because there's too much community transmission. So in this context, contact tracing fills the first T in this TTI strategy, and everyone knows what contact tracing is, so I won't go into any details. The traditional approach, which is the main approach that has been used so far, has some limitations. And it is because of those limitations where the idea of using technology arises. So the first limitation is that depends on the memory of the infected individuals, because they have to remember whom they had a close contact with in the past few days. The second limitation is that those individuals have to be identifiable, because the contact tracer needs to call them and perform the epidemiological interview with them. It is also difficult to implement across borders, and in situations where you have a lot of mobility, it might make very difficult to have this like cross-border collaboration. And then, as we all know, it is very resource intensive. So it is in this context where the idea of using smartphones arises, because we all have smartphones, and maybe our phones could detect, the proximity to other people, and we wouldn't have the limitations that the manual contact tracing has. And as you know, we can use different technologies for detecting proximity between the smartphones, but the most widely adopted one in Europe and in the US is Bluetooth-based. And it has already been described here. Bluetooth-based contact tracing has advantages, but also has limitations. So it is more privacy preserving than using other approaches like location or credit card transactions or cameras, surveillance cameras. It is more accurate indoors and in moving environments than, say, GPS. And as we know, Singapore was the first country to use it in the context of the pandemic. And there are loads of examples today, and you can find them, in a lot of websites. This is an example from the MIT Technology Review. But of course, using the smartphones is also not exempt from a lot of limitations. And many of the presentations today have discussed already some of the limitations and the security concerns around using Bluetooth-based contact tracing. So as it has been discussed, a certain level of adoption is needed, because otherwise the phones wouldn't talk to each other and it would be completely useless, right? And this leads, to concerns in terms of socio-demographic, geographic, and economic gaps. Bluetooth was not designed to detect proximity from other phones to do exposure, detection. So it does have a lot of technical challenges in terms of imprecisions, noise, sensitivities to the environment, which could lead to a lot of false positives and negatives. There is also some adoption issues related to the protocol that is used, which is the low energy standard. Not every phone is compatible with that. There is also the very big challenge that the phones don't have access to contextual information. So were people wearing masks? Was they encountered indoors or outdoors? Was there a protective wall between them? Were they facing each other or not? All that information is not captured by the phones. There are some technical issues with the need of running in the background, which was not allowed in iOS unless you use the Google Apple exposure notification interface, which leads us to issues of privacy, security, and asymmetry of power, as the previous speaker has discussed. A very concerning issue, particularly if both Google and Apple decide to embed this functionality directly in the operating system, where the amount of power that they'll gain by doing that will be very big. There are also human-centric factors that are less frequently discussed. How does the app communicate the risk, to people? What do people do with this notification is a very important element to address. And then many people, are trying to figure out what is the actual epidemiological value of the decentralized approach. How many false positives are there? How many false negatives? How many of the detected close contacts are actually positive? How does it integrate with manual contact tracing, which is a very important concern, because the idea is that app-based contact tracing is a complement to manual contact tracing, is not a replacement for manual contact tracing. So is the app working? I think there's a number of presentations on this. I just wanted to share some data about the Spanish app. So this is the percentage of shared text per number of cases. And we see that is a very low percentage that is happening today. And in the citizen survey that I mentioned before, we can actually gather some information about whether the app, is working or not. So when we look at a sample of almost 37,000 answers, in our sample, 35% of the people report having the app installed. So we do have a bias. It's a much larger adoption rate than the average for the population. The people that answer the survey are more digital, I guess, than the average adoption rate. So this is like a best case scenario in a sense. So almost 13,000 people report having the app installed. Of those, 982 report having had a close contact with a positive case. So they would be susceptible of receiving a notification. However, only 26 of them, so 2.6% of them, actually discover that through the app, of which only 9 report having gotten tested, so that's 0.9%, of which only 3 test positive, which is 0.3%. So the impact seems really very minimal right now. This is data for Spain, and we have similar data for Germany. But even going beyond the efficacy of the app or not, I think it's very important to take a step back and understand how it fits within the TTI strategy, and also what are the hypotheses that are leading to using the app. So one of the hypotheses is that an important portion of the infections might come from encounters with unknown individuals, because that's one of the limitations of manual contact tracing. The people have to have a name and a phone number, so it doesn't capture infections that could take place in a public transportation, or random encounter in the supermarket and so forth. But is that the case? So according to our massive survey with over 400,000 answers, for the first wave, between 70 to 80%, for the second wave, between 70 and 63% of the people who report testing positive report knowing who was the source of the infection. The most common source of the infection is the workplace, the household, and relatives. So it seems that for a large percentage of people, they actually do know where they got infected. The other important element is the second T in the TTI strategy. So we want to trace because we want to know whom to test. This implies that we have the capacity to test and implies that we have a very short delay between wanting to be tested and getting the test results, because we know from the literature that every day that we are waiting to get the test results is a day where we are potentially spreading, the virus. So it is the case for most countries that we have the data for that there is availability of tests. The purple bars represent the percentage of people that said that there were no tests available, even though they needed to get tested. And we got evidence that in the first wave in Spain, there was no availability of tests for around 10 to 15% of the people. But now there is really availability of tests. That's not an issue. The only issue that might be right now is these brown bars here, which are not very high in Spain, but they happen to be pretty high in Germany for some reason, which is the people that would refuse to get tested. Which in Germany is between 20 to 25% according to our survey. So the second T in the assumption TTI might not happen because there might be people that don't want to get tested. And then when we look at the time to get the results, in Spain, 80% of the people will get the results within 4 days. Still, that's a very long time. Ideally, 80% of the people will get it within the next 24 hours. So the contribution of the delay on getting the test results to the spread of the pandemic could actually be significant. And then we have the last element in the TTI, which is, okay, we want to trace because we want to test, because we want to know who needs to self-isolate. And the assumption is that the people who are a contact of a close contact of a positive case, they will be able to isolate themselves. But we do have evidence that this is not the case. In Spain, over time, this is from the beginning of May until now, between 37 to 51% of the people are telling us that they will not be able to self-isolate if they had to. And why? So there are gender and age differences on the reasons not to be able to self-isolate. The good news is that the most vulnerable, which is the people age 60 plus, almost 70% of them report being able to self-isolate if they had to. So that's quite positive news. The negative news, or the not so good news, is that a lot of the young people report not being able to self-isolate. This would be the darker, the darkest, so like fuchsia color and the dark blue color. This is the young people. And it's very worrisome that the psychological reasons are very prominent among the youth. Psychologically being impossible to self-isolate, which is over 20% for the Spanish youth, and then fear of stigmatization, which is also very high. And then we have an interesting gender difference for the people aged 30 to 59, where almost twice the women versus the men report not being able to self-isolate because of having to take care of children for men with in the same age bracket. There is another assumption, which is all equally exposed individuals have a similar probability of being infected. However, this assumption doesn't also seem to hold for coronavirus. And the parameter that measures this is the dispersion parameter, which measures how variable the spread of the disease is. And what has been found for SARS-CoV-2 or COVID-19 is that it has a very low K, which means that it has very high dispersion. And this leads to the fact that a very small percentage of individuals infect a lot of people. And that's why there is this concept of super spreading events and super spreaders. And this is also a very important factor to take into account. And in fact, because of this observation of this super spreading phenomenon, there are countries like Japan that are introducing the concept of backward contact tracing. So in standard contact tracing, you have an infected individual, and then you do the epidemiological interview or they use the app, And then basically you figure out who were their close contacts in the past n days. In Spain, for example, is past 48 hours. With the backward contact tracing, what you do is you ask for the source of the infection. And because you know that this person infected this person, because what happens is, because not everybody is infectious, a lot of the people are not actually infecting anyone. So the important thing is to identify the people that with high likelihood are actually infecting other people. And because we know that the origin of the infection at least infected one individual, maybe this person is actually more likely to have infected other people. So what you do is you identify the source of the infection, and then you do the contact tracing to the source of the infection. And then you go backwards. So you also identify the source of the infection, and then you again do the contact tracing to the source of the infection. So this is an interesting approach that has shown some efficacy in some countries. Another idea is to try to be a little bit more low key and to say, well, if people know the source of the infection, so maybe people themselves can spread some kind of coupons that would enable their contacts to get tested. And you can envision both sort of like privacy preserving or non-privacy preserving approaches to this idea, which we call ACDC contact tracing, where for every positive diagnosis, the person receives a number of vouchers for tests, or either the doctor, if you want to be privacy preserving, or the person distributes those vouching tests among the people that they think are most likely that they have infected, and then those people get tested immediately. So it's a way to sort of like scale the contact tracing using the actual population. And we have a paper up where we describe this. And what have I learned during all these months? So I have definitely learned that, you know, a pandemic is not just a public health problem, and a pandemic is not solved using technology. It is really a societal challenge that requires a holistic approach. And what we have been trying to do in Spain, and the mindset that we've been trying to change, is sort of like trying to inspire the decision makers into developing a virtuous cycle between these three elements. On the one hand, data, high quality data that will be captured and shared in a systematic way, data as simple as the number of cases or the number of hospitalizations, which has actually been really difficult and scarce and has led to a lot of uncertainties and also difficulties in understanding what the actual situation is right now. But also, you know, through the analysis of data, we can understand, you know, where we are, why we are where we are, you know, what is working, what is not working, and so forth. It is also clear that we need to invest in the right human resources, you know, of course, healthcare and social care, you know, personnel, contact tracers, teachers, researchers. But it's also very important that all these people are empowered with the right technologies and the right, you know, data to be able to do their work. There's no point in having thousands of contact tracers if they are using a piece of software from the 1990s and it takes them half an hour, you know, to enter each, you know, each contact. Or so I think, for example, I don't know, in many countries at least, one of the challenges has been connecting, you know, the technology with the right people and connecting the data, you know, with the right people. And then why would you want to do all of this? So ideally you do it because you want to identify weaknesses in the system, and you want to define public policies that would actually address those weaknesses. For example, if we know that a lot of people cannot self-isolate, let's create programs to help people self-isolate. Because what's the point of doing contact tracing if then the people are going to go to work, or they're going to go, you know, or they can't, you know, not isolate themselves and they infect, you know, everybody else. Thinking about all of this, just a couple of weeks ago, together with the Vodafone Institute and Data Pop Alliance, we published a paper where we talk about data and technology and contact tracing, you know, and COVID-19. And we sort of like put forward 6 recommendations that are very, I think, simple and kind of like commonsensical. I think the first one, and maybe the most important one, is, you know, how important it is that we act boldly and decisively. How, you know, we can take this crisis as an opportunity to really lead to positive societal transformation, something that was overdue before the pandemic, and that maybe, you know, with this pandemic, we can accelerate it. And this has been discussed a lot in this webinar, but we are also very concerned about the deployment of data and technology for other purposes that is not the pandemic, but just take as an excuse the pandemic. And of course, not every solution has to be technological. And I think it's fundamental that there is this sort of like holistic multidisciplinary approach. It should always put people at the core, and I don't think people have been put at the core in many of the decisions that have been taken. It's also become evident that we need to really invest in creating data literate human and data systems. There isn't a data culture and a digital culture in a lot of the public administrations in many places in the world, including Spain. And this has been a real struggle because they have been making a lot of decisions, sometimes maybe with this feeling that they were making blindly these decisions because there was no easy access to important data to be able to substantiate them. Something that hasn't been discussed maybe too much here, but it's important, is some of the really valuable data to help us understand the situation is privately held data. So how to create effective data sharing models for the public good, privately held data that could be shared for public good. And in that sense, I think regulation can be thought of as an enabler that would really help us accelerate and go wherever we want to go if we have clarity about what is it that we want to go. So from my perspective, some of the important priorities are really creating very efficient manual contact tracing teams of the right dimension, but also using the right technology. And from our evidence, the household, the relatives in Spain, at least because it's a very social culture, and co-workers would cover a lot of the contacts already. It is absolutely fundamental to protect the vulnerable populations because the health impact on them is the largest. And I think having clear protocols in nursing homes is a priority. As soon as there is an outbreak of coronavirus in a nursing home, it like spreads really quickly and most people end up in the hospital and in intensive care. So figuring out how not to have outbreaks in nursing homes, to me, seems like one of the most important priorities. The same for healthcare workers and essential services workers, which was one of the demographic groups or the social groups that was really affected in the first wave. I think it's also important to deploy policies for children. In Spain, it's very common that children are taken care by their grandparents, but it might not be the best of ideas. So, having a sick leave for parents, for example, of children that are sick or that have to be in quarantine because of having been in close contact with a positive individual, will be very, very important. And we can see from our data in the survey that a large percentage of mothers cannot self-isolate because they have to take care of their children. So they might not be enough resources to be able to do that. Because we know that SARS-CoV-2 seems to be a high dispersion virus where there are these events, this confluence of these three Cs, close environments that are crowded and have a lot of close contacts. It will be, fundamental to really minimize those events. And as I said, as important as the tracing is to having the capability to test fast, and also to provide quarantine infrastructure for the people who cannot self-isolate, which actually could be a lot of them, and for different reasons. So understanding the reasons why and deploying programs that address those reasons, be it psychological support, be it a financial support for the people who cannot self-isolate because otherwise they wouldn't make any money, or be it spatial support, locations where people could self-isolate, I think are fundamental. And this is all I wanted to share today. So thank you very much. And I encourage you to answer the anonymous survey. We have it in many languages and it's proven really, really useful and helpful to really understand what is going on from the perspective of people. Thank you.
Okay, thanks a lot, Nuria. Is there any question for Nuria?
Let me check. Please raise your hand if you have any question.
Yeah, I think people are getting a bit tired, but we still have program to go.
Don't someone was asking about the Spanish data. So we have this website and it's in English also. You can take here the link. I can type in the link on the chat and you can actually look at all the data for the survey for all the different countries. So the text is in Spanish because we don't have time to translate it to English, but you can see here the contact tracing, percentage of people that were in close contact and they did the contact tracing, and you can select the country, and then it shows you for different countries depending on the size of the sample. This is, for example, the data for the app in Germany. Also, only 3 people report being positive. So you can play with the data. You can read the paper where we describe the methodology of the survey. There's a lot more information about the survey that I didn't have the time to explain because it wasn't super relevant for the contact tracing. But yeah, if you have any questions about this or feedback, I'd be more than happy to send me an email, and we can I'd be more than happy to clarify them. Thank you. This is data for Germany, by the way. This is the people that say that they wouldn't want to get tested in Germany. And it seems really, really high compared to Spain, which is very low. So I don't know what's going on with the Germans. But
nobody knows what's going on with Germans. I will come to that later. Okay.
Thank you.
Thanks a lot, Nuria. If there is no other question, there are some maybe questions on chat if you have time. Oh, there is a question there. Somebody, Paul, do you have a question? And afterwards,
yeah, I tried to electronically raise my hand, but maybe I did the wrong thing. Hi, Nuria.
Hi, Paul.
I wanted to get your opinion on something. So I think that most of the people doing contact tracing apps took really a privacy first attitude. And as a result, the amount of information that was been made available was as little as possible in some sense. And you saw that in a lot of the talks, even in this workshop, security people tend to worry about privacy, less about, making data available. What's your thought on that? I mean,
well, I mean, for me, I even take a step back further, which is what I've been trying to share in this presentation. I mean, we cannot forget why we are doing the contact tracing. And we are doing the contact tracing because we want to know who needs to self-isolate. That's the purpose, because we want to break the community transmission. And the only way to do that is that the positive cases don't infect other people, right? So we need to identify very quickly who is positive, so they stay home and they don't infect other people. So from that perspective, I think it's important to look at the whole picture and to say, well, can I do this if there is a TTI, strategy, trace, to test, to isolate, how well am I doing the 3 pillars? So tracing is important, but testing is important, and isolation is important. And then on the tracing itself, it is true that, and I discussed that a little bit on the limitations for the Bluetooth-based contact tracing. What is the actual epidemiological value of the current approach? And I think the evidence right now is that it's probably limited and it's difficult to integrate it with the manual contact tracing, when the main premise is that the app-based contact tracing is a complement to the manual contact tracing. It's not a substitute of the manual contact tracing. I don't have a lot of insider evidence because there is no connection, at least for Spain, between the people that, so you don't know for a positive case whom of their contacts actually were identified by the app versus, the contact traces is not connected. I'm not sure it can actually be connected. So it's very difficult to figure out, how the interplay is. But the evidence that there is, if we look at the percentage of the shared text per number of confirmed cases, or we look at this other graph on, for all the people that have the app installed that had a close contact, how many actually end up testing positive, where we see that the impact right now with the current approach is very, very small. So personally, I don't think that smartphone-based contact tracing is a silver bullet that is gonna solve this problem at all. And that's why we have been trying to think about it in a different way, maybe using a low-tech approach, understanding how the virus is spreading, you know, understanding the fact that there's this high dispersion phenomenon, and you know, identifying what are the likely sources for infection, you know, and so forth, and then protecting the most vulnerable, which at the end of the day are the ones that are the most impacted by the virus. So while I am a highly technological person, for this particular problem, I am actually seeing that we meaning the computer scientists, we might be overly technocentric, and we might have lost sight of the big picture and of the overall, you know, complexity of the problem and of all the different pieces of the puzzle that need to fit together. And that's why, you know, I try to have a less technocentric approach, so to say, and a little bit more of a human-centric approach. Because at the end of the day, it is people, the ones that have to decide to self-isolate or not, or they have to be able to self-isolate or not. And as we know from the survey, a lot of people cannot self-isolate. So what's the point of knowing that you were in close contact with a positive individual if I cannot isolate myself for 10 days? I'd rather not know. And that's why there have been a lot of examples, including in Spain, of free testing campaigns where people did not want to get tested because they don't want to know if they are positive, particularly if they are asymptomatic, because the cost of being positive is right now too high. And the burden is on people's shoulders. So if you are a single mom and you know you are young, and if you don't work, you don't eat, and you cannot just isolate yourself and your kids, you know, for 10 days, so you rather not know, right? And there's a lot of people like this. And that's why we also have evidence, and there's been a lot of authors that have talked about this, about the pandemic, you know, being asymptomatic, meaning that it's affecting disproportionately different societal groups, you know, immigrants, people on the lower socioeconomic levels, you know, women. And we do have evidence on the survey that this is the case. When we look at the people that report being positive, and we look at the people that report being negative, and we look at their personal protection behaviors, which you have the data for, we see that they have similar personal protection behaviors. They have similar mask wearing behaviors. They have similar hand disinfecting behaviors. But when we look at their psychological impact and their economic impact, we see a very significant difference, where the positive ones disproportionately report with much higher percentages than the negative ones, having lost their income or their savings, having lost their job, or being afraid of stigmatization, versus the ones that test negative. So
Nuria, I need to stop
okay,
you.
sorry, I get carried away. But anyway, so we can talk more about this. Yeah. But basically, my main approach is technology is a great tool. We should absolutely use it. But let's not get overly enthusiastic about technology for the sake of technology. I think we really need to do a wise use of technology and understand the complexity of the problem and also the implications of using the technology, you know, the positive, but also the negative.
Okay, so I need really to cut it off because yeah, maybe we do another 5 minutes of break.
We have one question.
There is, well, no.
Okay.
No, because I think I really would like to have the question. Is that a question for Nuria?
It was a question from Claude. I don't know.
Yeah, Claude, you can write to her. I send you Nuria's email to you.
Okay.
You have no time, so.
Ciao.
Thanks a lot, Nuria. Thanks a lot for a very, very interesting and completely different view of things. This is why I really liked you to be on this web seminar. Okay.